have loved to introduce Ricardo Guertler, but unfortunately he could not make it to the conference to the US because of ill health. So I shall try to do my best impersonation of Ricardo and present essentially the next few slides on Chagas disease and some of the challenges that have been encountered there before we head into our questions and answer session. So Chagas disease, for those of you that don't know much about it, it's a disease that's caused by a protozoan parasite, Trypanosoma cruzi. And the infection is most commonly acquired through contact with the feces of an infected triatomine bug that bites humans or animals. And the complexity of Chagas disease is that it's a multi-host, multi-pathogen vector-borne zoonosis with multiple transmission cycles here in the wild, in the paradomestic and domestic environment, through a variety of hosts, some of which are wild, like the marsupials, rodents, cats and dogs, and then also ultimately within the domestic environment, humans. An added complexity of Chagas disease is that also there are a number of bugs that are essentially involved in the transmission of Trypanosoma cruzi. The main ones, Rhonius prolixus, Triatoma dimidiata, and then Triatoma infestans. Another level of complexity is that there are various phylogenetic lineages of Trypanosoma cruzi, all of which are actually also linked to the various transmission cycles, so wild, paradomestic, or domestic. Now, whilst most of the transmission of Trypanosoma cruzi is through the triatomine bug, there are also other transmission routes that also are becoming more and more important as efforts are made or were made to eliminate Trypanosoma cruzi transmission as well as Chagas disease from the Americas. So there's vertical congenital transmission. About 3 to 10% of newborns are getting infected that way. There are outbreaks of foodborne Chagas transmission as well. I remember a couple of years ago there was a very large outbreak in Venezuela when people decided to ingest raw sugarcane juice that was actually infested with infected bugs. And what resulted was essentially an outbreak of 30 plus cases there. You have transfusion-associated transmission, and that's why most of the countries, or actually all of the countries in Latin America, as well as the US, actually screen for Trypanosoma cruzi. You have also some cases of Trypanosoma cruzi transmission through organ transplants as well as laboratory accidents. Now, the disease itself is also quite complex in a way that there are two main phases. There's an acute phase, which can be sometimes characterized by some fever as well as swelling around the site of inoculation. And then there's a chronic phase. So after the acute phase, most cases or most infections go to sort of an asymptomatic, indeterminate phase. And then years later, possibly result in a chronic phase, which then is the actual Chagas heart disease. And that is actually the most common cause of cardiomyopathy in Latin America right now. Probably around 20 to 40% of seropositive individuals develop Chagas heart disease, and death can be caused by arrhythmias, congestive heart failure, and thromboembolosis. And it's the leading cause of cardiovascular death among patients 39 to 50 years old in endemic areas. So what is the current status of Chagas disease control? So in 1996, Chagas disease was considered by some experts as a disease whose days are numbered. In 2005, the target for interruption of transmission of Chagas disease set by the World Health Assembly in 1998 and others was not met. By 2007, WHO announced a renewed strategy to eliminate Chagas disease in the Americas by 2010. In 2012, with the launch of the London Declaration on Neglected Tropical Disease, a number of targets and goals for Chagas disease were included. Scroll forward 1 year, a clear strategy for elimination had yet to be defined, with variable progress on elimination efforts in endemic countries. And we're now 2016. And obviously that's the big question mark. What is happening with Chagas disease and its elimination efforts and the 2012 London Declaration goals that were set to eliminate the disease by 2020? One of the challenges is we don't really know how many people are infected with Chagas disease. So over the years, you can see that there have been various various numbers that have been put forth with regards to how many people are actually infected with Trypanosoma cruzi. And it's obviously made very difficult given the two stages of the disease that people can be in, especially if you have an acute phase that is very almost asymptomatic, and then this indeterminate phase as well that is completely asymptomatic. Now we do know that there seem to be some reductions in T. cruzi prevalence that have happened due to some of the control efforts that were done between the 1980s and 2010. But really, those decreases cannot necessarily be reconciled with numbers that we know of when it comes to chronic Chagas disease patients. So the annual death rates of those patients with or without cardiac involvement average about 8% to only 0.2 or 1% in the overall populations. We also know that the chronic Chagas disease patients are only a fraction of all of those that are infected overall. So the second challenge is around insecticide-based vector control. So the reductions in T. cruzi prevalence as well as transmission really occurred in the 80s and 90s when there was a broad-scale reduction in the geographic range of Triatoma infestans due to vector control, and it also resulted in the elimination of Rhodnius prolixus from Central America. Both those goals were achieved through large-scale insecticide-based vector control, primarily indoor residual spraying of households with insecticide, as well as very intensified surveillance over several decades. Here you can see where current transmission persists. So in brown, the areas with current vector-borne transmission by the main vector species, and then in red and light yellow, vector-borne transmission through secondary or wild vector species. And this gives you an idea of how successful vector control was. So this is the distribution of Triatoma infestans, which is essentially the main vector of Trypanosoma cruzi in Southern America. And between 1983 and 2003, you can see how that distribution was dramatically shrunk. Now, all is not good, though. There are certain areas in South America where it proved to be very hard to reduce the distribution of Triatoma infestans, notably in the Gran Chaco region. And this is a map of Argentina between 1964, 1992, and 2000, where you can see the infestation rate of Triatoma infestans reducing in a first stage, but then sort of stagnating at a later stage. And certainly that's a trend that has continued in the 2000s. Again, you can see here the domestic infestation rate in blue, and then the acute number of cases in red in the mid-2000s. And then here in the late 2000s, between 2010 and 2012, you can see that the domestic infestation rates really haven't changed much in those areas that were highly or that had high rates of infestation. Also, a multi-site trial in the Gran Chaco showed how difficult it was using vector control to try to eliminate T. cruzi infection and bugs. And so what you can see here in the red bars, those are house infestation rates on the left y-axis, and then the mean bug density on the right-hand axis. And what you can see is that despite blanket spraying and selective spray rounds at certain time intervals, it is very hard to not only decrease the mean bug density per infested house, but also the proportion of infested houses overall, and that still there's quite a proportion that remains infested. And partly that's because most T. cruzi transmission occurs in human sleeping quarters and nearby domestic sites. And so really the challenges or the limitations around vector control is that reinfestation that seems to be occurring from the paradomestic and sylvatic environments by triatom and bug populations. There's also a question mark around how rural development impacts house infestation and parasite transmission. And then over the decades, with all this use of insecticides in vector control efforts, of course, it didn't take long for insecticide resistance to develop, and certainly in Argentina and Bolivia, that is becoming a bigger and bigger problem. And then finally, just as, for example, in the malaria eradication program in the 60s and 70s and then 80s, decentralization of national vector control programs has also played its part recently in terms of eroding that expertise as well as the skills and the operations and infrastructure that were built up in the 80s and 90s to reduce the distribution of triatomine bugs transmitting T. cruzi. The third challenge is around the treatment of infected patients. I mentioned the acute and the chronic phases. The problem to diagnose the acute phase as well as diagnose the intermediary phase. An added problem is that there are 2 drugs available and they are effective, but only in the acute and early chronic phase. There are also some side effects, although they are manageable. And then finally, another nail sort of, I guess, I don't want to say in the coffin, but certainly another wrench in that equation is that the detection of cure is very hard. So the diagnostic tests that are available have their limitations in terms of sensitivity and specificity, and also the parasites are not necessarily, one cannot necessarily detect the parasites in, for example, blood or other tissues, depending on the phase that an infected individual is in. So current estimates are that less than 1% of currently infected individuals are believed to have access to treatment. So it's obviously a major public health and equity issue. Patients also ignore the consequences and the opportunities and limitations of current therapies. Again, if your acute phase is fairly mild or asymptomatic, then why really would you be worried? And of course, you don't really know what the chronic consequences of a T. cruzi infection may be many, many years down the line. So in terms of possible future scenarios, there are large-scale political, economic, and demographic and ecological changes that, as of now, we don't know what consequence they might have. Certainly in some settings, we've seen how deforestation has affected the reinfestation of houses by paradomestic or sylvatic bugs as they are looking for a blood meal. We also really don't know the full extent of the decentralization and associated loss of personnel vector control program, the vector control program, as well as the services, Chagas or T. cruzi specific services that were established. In some endemic countries, there's a relative lack of priority assigned to rural development following a rural to urban exodus. And certainly what we have seen is that urban areas in endemic areas such as Arequipa in Peru and Cochabamba in Bolivia and San Juan in Argentina have now peri-urban infestation and transmission. So previously, T. cruzi transmission was much more rural than urban, but now it's becoming much more urbanized following those sociodemographic and socioeconomic changes. And then, of course, there's the continued loss of social and political visibility of Chagas disease, maybe through the punishment of early success in the 80s and 90s. Coming back to that slide of what the current status of Chagas disease control is, clearly in 2016 a reboot of some kind is needed. We need better diagnostics. We need improved methods for assessing treatment efficacy and predicting disease outcomes. Certainly, discovery and development and testing of better treatments, regimens, and new drugs are needed. There's a need for integrated disease control management, since really those millions of infected people really need to be reached in order to minimize the current disease burden as well as prevent appearance of new cases, whether vector-borne or otherwise. And that, of course, requires funding, but also political will and commitment, as well as close stakeholder coordination and engagement. So hopefully I did Ricardo justice.